Well, hi, everyone. Welcome to the telemedicine segment. I'm super excited to be chatting with Raphael. He's the executive chairman of Medically Home. Raphael, thank you so much for taking the time. I really appreciate it.
My pleasure.
To give context to the audience, how did we get to this conversation? We looked at well over 500 companies, what we call within the telemedicine category. This could be quite vague, but one of the companies that really stood out to us was Medically Home. Their approach and their method of caring for patients, especially working and collaborating with providers, it has a really unique perspective for this ecosystem. And it's something that is really impactful. And so we're going to dive in a little bit into the product itself, how it works, and some of the unique aspects of why Medically Home is one of the best companies within the telemedicine category. So with that, Raphael, I think you provided with us a quick visual, a video of how your platform works. I think it's a great baseline to get the audience aware of Medically Home, and then we'll jump into questions.
Understandably, most of us get a bit anxious at the thought of a hospital stay. But what if that hospital could come directly to you? At Medically Home, that's exactly what we do. We bring the hospital to you, a temporary virtual hospital unit with the latest in high-tech hospital care installed in the comfort of your home, to provide care for patients and their families with expertise, safety, and trust. And that's only possible because of how we designed this system, by putting patients and their families at the center of what we do. So what's it like to be the patient of this virtual hospital? Well, it's all about the hospital finally coming to you and your family, with technology, advanced logistics, and from the heart caring. Just the fact that you can stay in your home and be 100% connected to your care team is amazing. Once you're admitted to your home, we connect you to your own physician and care team through our easy-to-use Mission Control Center app anytime, day or night. Clinicians and nurse practitioners provide in-person clinical services from the moment you're admitted and throughout your virtual hospital stay. And all the while, your health is remotely monitored by your nurses through FDA-approved medical devices. In fact, every service traditionally provided by a hospital is delivered right to you, placing IV lines, physical therapy, medications, infusions, x-rays, even nutritious meals. All you have to do is push a button and your doctor and nurse are there, just like that. Most importantly, doctors and nurses can really see you as a patient and a person. We can see into a patient's living space, how they walk, what they're eating. We're seeing the reaction on their faces when we talk about hard things. That's why it's no surprise to see patients more engaged, more empowered. That's why hospitals are seeing more available beds without the prohibitive costs of expansion. That's why Medically Home's program leads so consistently to greater patient satisfaction, better outcomes, and reduced costs. And that's why the future of hospital-level care is right here, in your home.
So, Raphael, great video. One of the things that, before I even ask questions about the product itself, the service, I'm curious if there's a backstory as to why you started Medically Home.
Oh yeah. So I'm an engineer by training, and I have background in healthcare services. And about 12 years ago, I was joining the board of an academic medical center. And as a coincidence, my dad was admitted into that hospital while I was going through that process. So I thought it would be helpful if I kept a diary of his care, and then I could share that with the interview process. And unfortunately, while I was watching, my dad passed away from 3 consecutive medical errors, which is how Medically Home was born. About a week after his funeral, I got a chance to look at the P&L of the hospital. And it was the first time that I actually knew or recognized that about 65 to 68% of the cost of a medical episode in the hospital is bricks and mortar overhead, which only leaves about 32% of the cost of care to actually deliver medical care. When I recognized that through my background and experience, I realized it was inadequate. The business model of a hospital does not allow for enough medical care for a patient to safely recover from medical illness in an appropriate amount of time. Because payments are fixed, the patient's journey through the medical system in a hospital is typically rushed, a lot of handoffs. And because of my background in factories, I recognized, the change in hands, the constant transfers, and the way in which patients were becoming part of an industrial process. And the thought struck me that if there's that much capital being deployed to support a patient's medical episode using bricks and mortar overhead, what if we took that bricks and mortar overhead and we arbitraged it out of the way we deliver care and spent that money instead on much more care over a much longer period of time in a site that's much preferred by patients, which obviously is their home. So I did a lot of research for the first year. I had been collaborating with Johns Hopkins Medicine in my previous business and discovered Dr. Bruce Leff's work in the area of recovering from acute illness in a home setting. And the data was pretty stunning over many, many years, over many randomized controlled trials around the world, and it demonstrated that patients felt safer at home, they preferred to recover from illness at home, they slept better, less falls, 16% reduction in mortality, less infection, and overall just a much better chance of recovery. So with that, combined with the financial information, I set out to build a virtual hospital. It was never about telemedicine, and by the way, it still isn't, although we are in the telemedicine category. It was about trying to figure out all of those really complex and extraordinary number of services a patient receives in a hospital. How could you possibly do all of that away from the hospital? Because telemedicine is a very small portion of that. If you need an x-ray, you can't telemedicine an x-ray, you can't telemedicine an infusion nurse, and you can't telemedicine a medical procedure at bedside. So the idea was to take every single discharge from the hospital, study it, and actually go one by one, what's actually happening at bedside in the hospital? Oops, I'm sorry. What's happening at bedside in the hospital, and what, if anything, could we do to take that centralized care delivery and decentralize it? Now remember, at that time, early days, Amazon was really coming up, and people were starting to get accustomed to things that used to cause them to go in their car and drive to get something. It's now coming to them. So there was a consciousness change when this all began around, well, maybe it could be brought to me instead of me having to go to it. So we iterated and iterated, and we discovered very quickly most of the things in the idea were not very difficult, but one was very, very difficult. And that was actually getting the services reliably to the patient at bedside rapidly. So we divided all of, this is about 11 years ago now, all of the services that go to bedside into a number of categories. One was, is the patient, how acute is the patient? In a hospital setting, there are typically 4 levels of acuity called severity of illness. It goes 1 through 4, 4 being the ICU, 1 being the lowest level of medical acuity. A patient would be normally hospitalized and admitted to the hospital for care. So we focused on each one of those, 1, 2, 3, 4. What services was the patient getting, and what, if anything, could we do to bring that to the patient to their home? And we decided to focus on level 3. Level 4 we knew would never happen. ICU level patient is just in much too fragile a condition. And level 1, that was already being done by hospital home programs around the world, particularly in Australia and Western Europe. We were most interested in 3 because nobody was doing 3. And the vast majority of hospitalizations are not 1s or 4s, they're actually 3s and 2s. So we got into it and discovered that we would need to probably do 4 things to enable this idea. First was we would need a medical command center staffed by physicians, nurses, nurse practitioners that operates 24 hours a day, 7 days a week. And in a hospital, there are nurses, nurse practitioners, and doctors around the clock. In the home, there isn't. So we need to create a surrogate for that, which meant the command center, always available. But most important in our learning, it wasn't just available to the patient. It was available to the patient's family. Because as we got into this, more and more we discovered, particularly with older patients, it's the patient's family that runs to the hospital. It's the patient's family that calls 911. It's the patient's family that's freaking out when dad or mom or my husband isn't breathing or being responsive. So the idea was to create this command center, make it available inbound for both the patient and the family around the clock, and outbound based on protocol. How would we care for this patient? How often would we interact with them? So that's the command center. We could centralize it. It could scale very easily because we could care for patients in Hawaii, in Puerto Rico, in California, in Oregon, et cetera. And that idea, other than cross-licensing physicians and other clinicians, it was a very scalable idea. And I had some experience, ran a very large call center in my past. Second, we needed technology in the home that allowed us to have access to the patient's status, their vitals, access to them visually, obviously have audio access back and forth, again, the patient and the family. We needed emergency power backup because in a hospital you have that. We needed backup cell signals because if we were going to connect with the patient through the internet, we needed to make sure we never lose connectivity. We needed an emergency response system in case something went wrong, and we needed a whole host of other supplies and medical equipment to turn that home into a temporary hospital unit. Let's call that the tech stack plus the temporary hospital unit. And that was the second thing. That was easy to get our brains wrapped around. So was the command center. The third one, not so easy. The third one was there are 18 services, Kyle, that go into the patient at bedside in the hospital. And they're either clinical services like an infusion nurse or a nurse performing a procedure, or they're goods like antibiotics. And whether the patient's getting services or goods, most of the time they're clinical services and goods. Sometimes they're non-clinical services and goods, like a meal at bedside is a non-clinical service and a good. So we studied every one of them and discovered there was a very large amount of those services already available in the community. However, they were available for something called a post-acute care world. They were available for patients who already were discharged from the hospital. Because those companies operate on such a very, very tight margin, they don't have excess capacity. They don't have people waiting around to rapidly dispatch to the patient's home. In a tight margin business, you have to literally operate your staffing very, very tight. So if I needed to send a nurse in the next hour or a paramedic in the next 20 minutes to a patient's bedside, there's no excess capacity in the post-acute services in the community world. So we had to rethink, how do we take these services, these capable people and talent, and turn them into an acute supply chain? In effect, elevate them, amplify them, accelerate them, and change the level of reliability, because as you move up in patient acuity, the risk to the patient goes higher and higher if you have less and less response time. Does that make sense? So we had to basically put together a way to restructure the entire supply chain that already exists in the community that would ultimately have to be turned into an acute supply chain. And that was 11 years ago. That focus over the last 11 years has differentiated us from anyone in healthcare, anyone in telemedicine, anyone in hospital care at home, because that's the it. Everything else, to get to a patient, to send a physician to a house call, to have a physician do a telemedical visit, not hard to imagine anymore. What's very, very difficult is that physician orders 9 things. He orders oxygen, an antibiotic, an x-ray. He orders a Foley catheter. He orders all those things. And he has to know, or she has to know absolutely for sure it's going to get there and in time. Because if he or she doesn't, he or she is going to say that patient belongs in the hospital. Much too risky. So the supply chain, Kyle, was the big idea, but the most challenging part of the idea. So that was the third leg of the stool. The first was the command center. The second was the tech in the home. And the third was the supply chain. The fourth was as challenging as the third, but we could imagine how we would do it. The fourth was, how do you take these hospitals? We didn't want to compete with hospitals. We wanted to support them, help them make the transition to this new world that we saw coming. So our idea was, how do you take this platform and integrate it with Epic or whatever EHR system they have? Let's say it's Cerner or eClinicalWorks, because they just made a gigantic investment to automate their electronic medical records. And if we walk in with a parallel system and they have to go use both systems, that was not going to fly. So independent of everything, we knew whatever we built would have to seamlessly integrate with the existing host electronic medical records. So that was the big effort. And the last was to take software and actually purpose build all of the things I told you, including the ability to track, where's the oxygen right now? When is it coming? Who's the oxygen therapist? What's her background? All of the things that basically operate a virtual hospital has never been built before. Epic doesn't have it. No one has it because no one's ever operated a decentralized hospital before. So we had to build all of that from scratch. And we had to have it integrate with Epic. So those are the 4 big things we had to build, and it took a long time. This is independent of getting regulatory approval, reimbursement, any kind of investor. This is all self-funded by myself and my 2 partners. So we went through that process, and eventually, 4 years ago, we launched in Boston with Atrius Health, Harvard Vanguard, and had some success, and then the pandemic. The pandemic drove everything that's happening, I would say. The momentum of it is the pandemic, and it's not the COVID part of the pandemic. It's a change of consciousness about whether hospitals are even safe anymore, whether they have the capacity to flex up and down based on demand, and most importantly, whether their business model is friendly to patients as they've now experienced telemedicine, and then wondering, in some cases worrying, do we have the right business model going forward? So that's the long-winded history of Medically Home. It started with my dad. It went on a journey, mostly an engineering journey, a research journey. Along the way, we did a clinical trial and published it to prove that the model was safe. Along the way, we took many, many partners that are now, I'm happy to say, part of our ecosystem. So that's the history of Medically Home.
Absolutely incredible. First, I apologize, or I'm sorry to hear about your father. And I think, you know, for a lot of companies within healthcare, what's the most unique about this space is I think many founders like yourself have a very personal story, which drives that mission forward. And it almost is necessary in a space that's so complicated and so difficult. The second thing I want to mention is, yeah, you're absolutely right. Telemedicine as a general descriptor of Medically Home doesn't do justice. Absolutely not. And I think that's one of the things that we wanted to highlight you because of it's much more than just a video chat, fee-based service conversation with the doctor, where you are building out an ecosystem beyond that. Now, I want to kind of go into the specifics of those 4 parts so that the audience truly has an understanding about the complexity of this and why it's important. The first one I wanted to start with was the patients themselves. Now, you talk about how your focus specifically on that level 3 acuity of patients. Does this, is this for that type of patient? Is it specific to different types of illnesses, conditions, diseases, or it's any level of acuity or level 3 acuity patient that would fit within your platform?
Yes and no. The challenge with diagnostic specificity is it's very, very complicated, but the simple answer is it crosses all diagnoses for level 3 patients, but some patients and some diagnoses require a special kind of care that can only be safely delivered in the hospital. So today, as an example, is a level 3 pediatric patient that we're only caring for today in a hospital. In the next few years, we'll be caring for that patient at home, a pediatric patient. Today, we don't do transfusions in the home for patients who have blood cancer. In a year or 2, we will be doing transfusions in the home. So there are specific procedures that are hospital domiciled today, irrespective of acuity level, that require sensitivity for the model to be responsive. So that's one way to think about it. Another way to think about it, the patient's home is just not safe, Kyle. It's not safe. They either have no home at all, they're homeless, or they have some very specific challenges, and we're making arrangements now to overcome that, which I'm very excited about. That will be launched next year, to actually create a temporary home for patients, not a hospital. So the best way to think about it is patients who have the most traditionally frequently hospitalized diagnosis, CHF, COPD, UTIs, cellulitis, those patients are ideal for the model. Patients that are old and frequently hospitalized, they're also chronic and comorbid. They have multiple conditions at the same time. The model is ideal for them. Patients with cancer, the model is ideal for them. Patients that are frequently hospitalized, and even though we don't need to substitute the hospital, we substitute to the emergency room. So let's say a patient has been admitted in the hospital 3 times in the last year, and let's say they've been to the emergency department 4 times. We make Medically Home available to them 24/7, and they push a button, and then the emergency department comes to them instead of making them go to the emergency department. 85% of the time, that patient doesn't require hospitalization. They've been resolved, maybe observed, and now the episode technically is over and they're back into their lives. But sometimes, 15% of the time after that emergency visit to the home, they have to be hospitalized, but now they don't have to go to the hospital to be hospitalized. They get admitted from their living room to their bedroom in their own home. So I would say there's a large suite of diagnoses that are amenable to the model. They typically line up with level 3. There's certain things that are exclusion criteria, and I think I've covered all of those.
Awesome. Yeah, thanks for the clarity. How does a patient where's the decision factor, or who's making the decision on when the patient should be using Medically Home? Is that directly coming from the patient, or is that the provider that says you're probably fit for the service and you could probably go back home?
Two answers. The first is the second part of your question, which is the primary drivers for the model today are the option is presented to the patient and the family. You need to be admitted, Mrs. Smith, to the hospital. You have a choice. You can go upstairs and be admitted to a med surgical bed, or we can actually set up a hospital bed in your home. Which would you prefer? And that conversation is between the provider, the patient, and their family. That's the primary driver. The new driver, which just began with Medically Home a few weeks ago, is a patient has the wherewithal and says, you know what, I don't want to, this is a cancer patient, I don't even want to deal with the hospital system anymore. So tell me what it would take for me to have Medically Home care for me forever from now on. And that's a direct-to-consumer application. We just started. It's been very, very exciting because if you're a person that requires medical services all the time, navigating the health system is challenging, and particularly if you have cancer.
Wow, really interesting. And so you are becoming the provider itself for these types of patients.
When you say we are, well, our customers are. So I should probably explain our business model. So I apologize for not doing that. So
it's okay.
We began believing that no one would believe that it was possible to take care of high acuity patients at home. We knew no one would believe it. And if we presented the idea, they would say it's too dangerous, or we can't do that. Or we wouldn't have anyone accept it because it would have a lot of resistance, particularly clinical resistance. So we knew that we had to do it first in Boston, which is where we launched. So we built a medical command center, a big one, staffed it, and started caring for patients with our own physician group, our own nurses, our own nurse practitioners, our own supply chain, captive. Everything we did, we codified in software. So we, in essence, collected all of the insight and knowledge, the IP, that allows this model to happen. And then, little by little by little, hospital systems heard about us. We had a lot of PR in the beginning of our journey, and they said, is there any way you'd be willing to teach us how to do this? Could we do this instead of you doing that? And we said, that's been the idea from the beginning. So in effect, we're creating virtual bed capacity for them. We provide the software. We provide all the training. We stand up the command center for them. We provide quality control, user support. So in essence, it's their clinicians, their brand delivering care to their patients. We enable it, and that's the business model. So everything around direct-to-consumer, everything I've shared with you, is what our customers will be doing with patients. We're not competing with them.
Gotcha. Thank you for the clarification on that. And you mentioned earlier about 18 different services or solutions that are typically used in a hospital setting. Can you give us insight about what are the tools or equipment or devices that are used in home? Where are you getting these? Are these third-party companies? These something that you built yourself? Where does this come from, and what are they? What are those? Can you give us an example of some of those 18 services?
Sure. So we're all, the founders are all engineers, so we're a bunch of geeks. So we geeked our way in the beginning, and I'll tell you a wonderful story how we geeked our way into this, because it is a good story. So I have some colleagues from WellPoint, which is now Anthem, and I said before I started this crazy journey, I knew it was going to be a very long journey. I want you to take a whiteboard and tell me how much of the savings we're going to create you're going to want to keep, because I could go through all this effort through all these years, and then in the end, there's not enough malted for the three straws in the malted, meaning us, our customer, and the payer. There had to be enough pie in the pie pan. So I needed to understand that first. And I went through a pretty significant amount of diligence through the lens of a payer of what kind of economic benefit they would have to enable this model, not stop it, in other words. So that was a big part of how I began. Then, because of the diligence we did on every single service in the hospital and then the equivalent in the community, I knew exactly how much it would cost to care for a pneumonia patient that was level 3. How much oxygen, how many visits, how many x-rays. I knew exactly what it would cost. So let's just make up a number. Let's call it $5,000. I also knew that the number of times our command center would have to talk to the patient and how many times the patient and the family would call us. And let's call that $2,000. Just make up a number. So now I'm $5,000 and $2,000 in terms of cost. I also knew how much payer savings they had to keep, and I knew how much the customer wanted. I also knew how much profit margin we have to be sustainable and have a return on investment for our investors. That left $13.75 a day for the tech in the home. So I didn't start falling in love with technology, even though I'm a geek. I fell in love with $13.75 a day, and times 30 days, you just basically have about $500 to spend, roughly. So what could I do for $500? I knew I had to manage their vitals, so I looked at every blood pressure cuff, every pulse oximeter, every patch, cardiac patch, looked at every scale, looked at every router, I looked at everything. Backup power, battery power. How many days? 3 days, 6 days, 9 days. How much backup signal? 1 backup signal, 2 backup signals. So as you go through what you could do with $13.75 a day, and then you walk into what you have to do to keep the patient safe, and you find the balance, and then you drive on the technology and on the service to make it reliable, make it safe. So the tech in the home is a series of vitals monitoring. It's all third party, although we did take a scale and we modified it because some patients with COPD have challenges with their weight, and when they step on the scale, the reading is sometimes inaccurate at home. So we built basically a guardrail where the patient could stand on the rail, which doesn't affect the accuracy of their weight. We attached a Bluetooth device. We actually modified an existing scale so it's much more friendly and user-friendly for patients. But other than that, everything is third party. It changes frequently because the technology improves all the time, particularly vitals monitoring. But in the home, we have vitals monitoring, all the major vitals that we need to monitor, both real-time and intermittent, backup power, backup cell signal, durable medical equipment, whatever the patient needs. If they need a bed, we provide that. Whatever they need, we provide it. Supplies, backup medication, anything and everything they need to enable the home is kitted and provided at the time they're admitted into their home, which is done in less than 40 minutes.
Wow. Impressive. Really impressive. And this kit that you're talking about, is it one standard kit for everybody, or is it also, do you pick and replace different products depending on the different types of patients?
It's a base kit, and then obviously as the patient has specific and unique needs, we'll augment it appropriately.
Gotcha.
But everybody gets the technology in the home, and the degree of modification depends on a number of factors, particularly it might relate to their home.
Yeah, it's definitely, you already highlighted this, but being able to manage patients from a distance. A lot of what we call the traditional telemedicine services seem very, very limiting what you can do. It's really, talk to someone over a video chat. It's do you have a cold? Do you not have a cold? It's very surface level. And for you, you really go in depth with not only bringing in the different vital signs, but actually being able to have care on site in someone's home. It takes it to a completely different level of what is remote care and virtual care. You talk about one of the challenging parts was building out, being able to have an ecosystem of nurses or practitioners or providers that actually can be available in home taking care of patients. Can you give us a perspective how often these individuals are in the home? What happens in a situation when a patient reaches critical status? How many times do they have to intervene in patients at level 3? What have you seen in this space? How do you manage this process? I know it's a lot of questions in one, but
no, it's fine. All of the thinking underlying what goes to the home early was defined by some experiences we had that were very illuminating. And one of them was, you better start using paramedics. That was the first illuminating experience because they love emergencies. They're fast. They're everywhere. They're cost effective. And they love to be tethered to physicians, meaning here is the patient, decentralized, here's the physician, centralized, here comes the paramedic to bedside. That paramedic is already comfortable being connected to the doctor and serving as the eyes, ears, and hands of the physician. Even though they have a license to do a lot of things, they're comfortable, not more comfortable, they're comfortable being tethered. So in our model, we need it fast, we need it reliable, and we need it tethered. Because if a patient's complicated, you can't put the doctor in a car and send them to the home, they're centralized. So we needed someone that could be at bedside as if the doctor was at bedside. So that paramedic early on became a very significant point of focus on how we build out the supply chain. So back to your question, what comes and how often does it come? Depending on the patient's acuity, a paramedic can come as little as 4 times, as many as 15 times during a 30-day episode of care. The average day in the first 5 days of care, the number of visits or visitors the patient will have will be between 5 and 10. As the patient starts to recover, those physical visits to the home decline because the patient's recovering, and that could be down to 2 or even 1. And as the patient's medical complexity and medical status improves, the need to actually put people in cars to go to their home obviously declines. The key is you have to divide every service going into the home into 2 buckets. Bucket 1, scheduled, meaning I know tomorrow a patient had surgery, I know they need a wound dressing change, and we need to check up on their assessment, do a face-to-face assessment. I can schedule that. Today is Saturday, I can schedule it for tomorrow on Sunday. All of a sudden, there's a change in patient's vitals, blood pressure drops, temperature goes up. I need a paramedic at bedside now, right now. And I need to check on them. I need to see if I need to order an x-ray. I need to get an x-ray for the patient now. I need blood tests now. So all of that divides pretty much emergent versus, urgent and emergent versus scheduled, and paramedic versus other. That orientation allows us to do the types of services and the speed at which they need to be done. And again, all of that we learned through a lot of iterative experience with high acuity patients.
Interesting. It's really impressive that you've solved this problem because I feel as though in these situations, especially working with your primary customer, which was the provider themselves, a lot of them seem like they're afraid of liability. They're afraid of any issues that could cause any type of problems. Are you worried about risks having taken care of patients in home? Is this something that's a huge hurdle for a lot of the customers that you're working with? And how do you manage that?
Well, 97,000 people die of medical errors in hospitals every year. It's the 3rd leading cause of death. It's equivalent to about 3 737s crashing every single day, and it never makes the news. So it's a massively dangerous business, the hospital business. And the errors are well known. They're typically from infection, falls, and they're in many cases difficult to resolve because the site itself is a factory of germs, and it really isn't designed to help a patient recover naturally from illness. Their bed is too high. The bathroom is not their bathroom. Everything about a hospital, they're not ambulating, they're not moving around enough, they're not walking their dog, they're not checking mail, they're not sleeping. And when we first started, one of our patients said, the last time I was in the hospital, they woke me up at 3:30 in the morning to give me a sleeping pill. That summarizes the hospital for me, she said. So hospitals are dangerous. Being sick is dangerous. Medicine is dangerous. The home has been proven to be much safer. All the data, the randomized controlled trials have been around for a long time. They're published and by the top academic medical centers. So do I think about and worry about liability? Of course. Do I worry about patients much more than I worry about liability? It's dangerous to be sick. And it's dangerous to be old and sick because there's still a lot of judgment involved in making decisions. Those decisions are made by the physicians of our customer, but it's still a very heavy burden. Are they worried about it? Everyone's worried about medical liability because it's a large burden. But I think as physicians, our customers get the feedback from the patients, which is always extraordinary and exceptional, and they realize this is what they want to do for their own mother, then there's a mindset change. There's a mindset change, and the mindset change is not whether the home is less safe than the hospital. The mindset change is, am I ready to embrace the risks that are associated with caring for patients because they're in a new setting, and that old setting is very familiar, including liability. The new setting isn't that familiar. So there is discomfort, Kyle, but depending on the customer, depending on the feedback loop and how long that feedback loop operates, customers come along and they get very excited about the model. And patient feedback is the medicine for that fear.
Yeah, it's it definitely makes sense, and especially in the times that we're in today. I'm curious, what does that onboarding process look like to a provider? You know, how does it change their workflow? And you talked about earlier some of the mistakes that are happening within hospitals is too many transitions and poor communication. Is this something that's changing in new provider, in using your services and solution, and has that improved?
Well, I wouldn't say it's improved or not. It's just different. So when you're onboarding a patient into the model, let's say they show up in the ED, the patient's not used to going home when they need to go to the hospital, and they're not used to their home being called the hospital. So the onboarding and the workflows associated with onboarding the patient and the family is new, and providers get used to that. The second is getting the patient physically into the home and oriented, and then having the initial care call happen while there's somebody physically present. So we always say that we're virtual plus physical care perfectly integrated, not telemedicine. We're both. We use telemedicine, but no different than anybody uses any kind of technology. The real workflow changes are the integration of acute care with post-acute care. We don't believe in post-acute care. Our philosophy is either you're sick or you're not sick. You're not post-hospital sick. You're sick or you're not sick. And when you're not sick, you have a clinically stable clinical endpoint. You're stable. You're not at risk for having a decompensation quickly. That clinical endpoint of stability typically takes between 7 and 30 days, not 4.5 days, which is the average length of stay in the hospital, which is why we are such heavy users of skilled nursing facilities after the hospital, why we have such a high readmission rate into the hospital, because the time in the hospital is inadequate, not because the hospitals are bad people, quite the contrary. The financial model does not allow them to keep the patient in long enough to have a reliable recovery. It is a fundamental business model problem with hospitals' fixed costs. And by the way, stay tuned. In the next 2 years, you're going to hear the exact same thing about colleges and universities. It's just the cost of educating the student, the bricks and mortar of educating the student after parents have borrowed $60,000 to watch their kids go online in their living room and have an education. There's going to be a revolution in colleges and universities for the same exact reason. The fixed cost burden, our absolute appetite for buildings. My colleague from Hopkins left calls it edifice complex. We're so in love with buildings, particularly in healthcare and education. That penalty allows the system to rob the services from the end user because the cost and the burden of those facilities are so high. But until now, it really hasn't been in the crosshairs. And there was a big article last week by Fast Company, which came after the Time Magazine article about this issue, specifically about the fixed costs of hospitals, which, by the way, is $800 billion with a B. And that's the exact amount of money to spend on defense. So just imagine you're the President of the United States, or imagine you're somebody else. Imagine you're making the decision, do I spend money on defense or on buildings for hospitals? Because it's the same amount of money, $800 billion. And that burden on our economy is so large, on our ability to shape policy is so large. So where are we getting the money? We're borrowing it from China, which is now our new best friend. Not. So the whole architecture of our financial system, funding buildings that don't deliver care, in a lot of cases, that we borrow money for and compromise on other programs and other national necessities, that interplay is now becoming strategically more relevant and more transparent. And I think that's what's going to drive change, is the economics just don't work anymore.
Yeah, really, I'm absolutely blown away by that that number of overhead, $800 billion in that comparison to the military budget. Wow. It really puts things in perspective. And with that being said, kind of going, highlighting back to the last point, I'm curious, in the very beginning you mentioned and it seems like for most healthcare companies, it's really challenging to integrate with EHR systems and being able to interface and just build yourself into the existing workflow of providers. And you talked about that was something that you've worked on. What does this look like from a provider standpoint? How is it, how have you actually built yourself into, providers' workflow and EHR systems? And does anything really change too much?
It's actually relatively straightforward. So they continue to write their notes and their orders in the host system because they're used to doing that. But everything that operates the model, dispatches the care, bills for it. I mean, everything that tracks the individual providers, tracks status, turns data into an alert. Let's say a patient's blood pressure changes and there's an algorithm that says that's the definition of an alert. The alert goes out. We don't put all of the data on every single lead that comes from the vitals monitoring in the home into Epic. But if there's an alert, that goes into Epic, as an example. A medical order is written into Epic, then goes through our system so it can be fulfilled. A note, a doctor's note, who's attending in our model goes into Epic. So what we've done is we've taken those essential services that physicians are comfortable with and are accustomed to already in the host medical record, and we keep them there. But then we create hooks between our system and the medical record to allow this thing to seamlessly operate. What went in, what wasn't going to go in was a big decision early on, and it continues to be a very important decision. Epic is trying to create its own hospital home software program. Everybody will, because it's rising in popularity quickly, but the Epic still doesn't understand that it's much more than a bricks and mortar hospital going to the home. It's a gigantic logistics system. It's a whole host of things that are not native to the way you operate a hospital, but over time, I believe Epic will have a hospital home software program.
Interesting.
That's why they're called Epic.
Really interesting. At this point, it kind of already seems obvious, but just for the audience perspective, I'm curious on your standpoint and your position in this. When you're working with providers, I'm just curious, what are those deliverables that you talk about or pitch to them, and what really resonates with providers when they're working with medically home?
You mean before they decide to or after they decide to?
Either way, both.
So I have on an average day now 7 inbound calls from providers. In the entire 11 years that preceded this time, there weren't 7 calls. There weren't 3 inbound calls. There were 5 outbound calls. So 7 a day. And it's hilarious because I'm like that high school kid that could never get a date and gave up on asking women to go out. And now I'm sitting and the phone's ringing off the hook and I don't know what happened. It's not plastic surgery, that's for sure. So I would say that they have a point of view that they've evolved on their own independent of us. And I'll give you the feedback I've gotten, which is reliable in terms of if your audience is investing in healthcare, this is a reliable, probably statistically significant piece of data because I think I've talked to 130 systems now in the last couple of months. Even though there's 5,700 hospitals, the ones I've talked to represent probably the most significant portion of the academic medical centers, the specialty centers like oncology centers like MD Anderson, et cetera. And then it also represents the small community hospitals. So it's a good cross-section of the country. So they're calling for 4 reasons. One is Mayo announced that they're doing this with us. That's the first reason. Why does Mayo Clinic need medically home? And then we have other partners, which I'm not going to mention, but they're all announcing. So, like, what do these guys got that these guys couldn't do on their own? So that's the first reason they're calling, because there is a mentality in healthcare that if the leaders are doing something and we're not, what did we miss? So that's the first reason. And they always ask me, like, why did they decide to do that? Why didn't they do it on their own? That's the first question they ask, Kyle. Second, our hospital is full. That was a call I had this morning. Our hospital is full. We have 3 hospitals. They're all full. we've got a budget to build a new tower for 40 beds at $2 million a bed. That's $80 million. That's the tip of the iceberg. The iceberg is what it's going to cost to maintain those beds. We've been reading about overhead. It's like, why are we building a hospital? Why don't we build virtual beds? That's the second reason they call. They're full. The third reason they call, they have risk contracts. They have an ACO. It's small. It's emerging. They're dabbling. You know, they have 20,000 lives, 30,000 lives. But they know this is what's coming. They know CMS doesn't have enough money. Back to the fixed cost problem, borrowing money from China. There isn't enough financial capacity in the system to keep paying for hospitals. And they know that because they run the hospital. And their CFOs know that because that's why the CFOs are looking for new jobs. They know that the financial sustainability of hospitals is very, very shaky. So they want to get into a model that is patient branded with their hospital system, yet less costly. So instead of saying, I'm putting you somewhere else, I'm putting you at home. I'm going to set up a hospital in your home. The system. So do I make as much money as I make putting you in the hospital? I actually make more in a home hospital model. However, I have to backfill, meaning I just lost the patient to contribute to overhead in the hospital. My overhead is $7,000 in 4 days. That patient didn't get admitted. I don't have another patient. I'm still spending that $7,000. I need another patient. I need to backfill. So if I have a risk contract and I'm serious, that's another motivation of why they're calling. The fourth reason they're calling is the most interesting. All of a sudden, patients said, it's really dangerous to go to the hospital. I could die there. And my family's not allowed to visit me, and I could die there and not see them before I go. I don't go to the hospital. I'll stay home. And the number of people that are getting more and more ill at home because they're afraid to go to the hospital is growing. Rates in most, I shouldn't say most, in significant medical centers, the rates of ED activity has gone down significantly, and so has elective surgery because of fear of hospitals. So the fourth reason they're calling is, we've just assumed for 150 years that you're coming to us. You're not like not coming to us. We just assumed you're coming to us. And now all of a sudden you're not coming to us? You have insurance and you're not coming to us? What are you doing? I don't want to die. I don't want to come to you. That's the fourth reason they're coming. Now, the fifth reason they're coming is they got a combination of those things, and they're calling fast. They got people are not coming, they're building a tower, they're full, and they have a risk contract. I have a screen, a grid that I keep with like why they called, but if you take the change in orientation around COVID sensitivity to hospitals, combine it with Mayo's decision to partner with us, everything else in the middle kind of goes along for a ride, and that's why they call. And the calls, I no longer have to convince them of anything. I don't try. I just sit back and do what I'm doing now, just listening and answering questions. There's no more of that anymore. I'm not leaning forward anymore, which is great. At 68 years old, it's wonderful to lean back.
It's a great position to be in, especially after 11 years now. You said that you've been working on this problem. It's nice to see that come. 12. Wow. And I know we got about 10 minutes left, but I only had a couple more questions for you, Raphael. What is this you have such an interesting relationship compared to most healthcare software solutions and services with providers, or at least your customers. And it's very hands-on. It's very complex in some cases. What does that business model look like? Are you just the outsource? I mean, you're using the resources of the provider, the customers that you work with, but you're providing basically the end-to-end solution to manage the patients for them. How does that business model work?
It's relatively simple. We basically license virtual beds. So if you want to have 100 beds, if you were building a 100-bed hospital, you understand what that costs. If you want 100 virtual beds, all of the tech has to be set up, the command center has to be set up, the supply chain has to be set up for 100 patients. So you tell us what your census is that you're committed to putting into the model, and we'll build out all the capabilities. And for every virtual bed, we charge in effect a licensing fee to be able to handle the virtual bed, to support that. This is the kind of model, forget the business model for a moment, this is the kind of model that if hospitals genuinely continue on the momentum they're currently on, this is a $300 billion industry, because you've got the costs in the hospital that are being basically substituted at the home, and then you have all of the services that are currently in the hospital going into the community. You have all of the medications that are being sold to the hospital going into the community. Just think about it, the x-rays that are going in the hospital going into the community. So you're shifting massive amounts of capital. Valuations of companies that are focused on just delivering to a hospital are going to get affected. This is a business transformation where centralized care, I mean, this is Amazon versus Macy's. This is, all of a sudden, you're not making the customer drive to the mall. The whole mall is coming to the customer's home. And then when Amazon bought when bought Whole Foods, which a lot of people didn't expect, it's the perfect answer. You get everything. You got the physical place, and you've got the virtual place, and you got the logistics coming together to basically surround the patient with everything they need. So Amazon plus Whole Foods is, what else do you need? What else do you need? You want to go to the store? You don't want to go to the store. You want to get it now? You want to get it tomorrow? So that's not our idea. I'm not taking credit for any of that. It's what patients and consumers want. It's just no one's thought to do it in healthcare. And Kyle, the way you asked your question, I have to tell you something. Back in the day, because we got turned down 168 times for financing, not 50, not 100, not 150, 168, but who was counting? 168 times people said, what a great idea, fantastic idea, just way too early. Come back when you have 100 patients. So I did. Come back when you have 500 patients. So I did. Come back when you have 1,000 patients. So this is really hard to wrap around your brain around, because from an investment perspective, a traditional PE or VC investor, this is just too complicated. It just is. And I'll be the first to admit it, but the people running this company are engineers. There's nothing too complicated for an engineer. To go to the moon, the day we decided to go to the moon, there was no fuel, there was no rocket, there was no suits, there was nothing. So it took 10 years, by the way, to go to the moon, but we went to the moon. In the same way, to do something like this through the lens of a traditional investor, there's just too much complexity. Having said that, we are about to, Medically Home is about to start carving out components of what we built and make it available to everyone, and actually create competition for us. Pieces of what we're doing, we don't believe it's right on behalf of patients to just restrict what we're doing on the patients that represent our customers. So we're in the middle of that. I'm in the middle of that right now, and I'm extraordinarily excited about that. And I started presenting that to a few investors, and investors say, I want to do that, because that's already proven, it works, it's scale, your partners, we all know who they are, it's not complicated. So I couldn't start with that, Kyle, because I had to prove that the integrated model worked first, so that we could take these, carve-outs, if you will, to allow them to happen. So through the lens of an investor, I wouldn't spend money investing in hospitals right now. I just wouldn't. And I definitely be careful who I invest in to follow this trend. But there are a lot of opportunities, and they're coming big time.
Well, I agree, and I think it's an interesting outlook. For sure, you took the hardest path out of everybody across the entire ecosystem, and kudos to you. I mean, it's absolutely impressive, and I think with that, it's truly transformational in the method of care, and it's the hardest problem. I mean, it's not just a hardware problem. It's not just a software problem. It's not just a service problem. It's not just a relationship problem. It's all of it. And so it's really impressive. Do you have a couple more minutes? We might go over a little bit of time. Is that all right? Okay, great.
Of course.
You already highlighted this in your last, what are the reasons about the deliverables of why individuals no longer want to go to hospitals. But how has the pandemic changed your business?
It's such an odd, I don't even know how to say this. I hurt for our country, I hurt for the world with all the suffering that people have had to endure with COVID. A number of my kids have had it, my grandkids have had it. Colleagues have had it, our chief medical officer has had it, our chief nursing officer has had it. So it hurts at a very, very deep level. So there's a part of me that feels like, how could I possibly celebrate a pandemic? But the pandemic has been a rocket ship for Medically Home. Before the pandemic, there was activity, it was measured, it was cognitive. Since the pandemic, it's emotional, it's driving, it's a propellant. It's very, very hard to describe because I think it's not the pandemic, it's the lack of preparedness that we had across the board, and the healthcare system appears to itself to have failed. It failed in testing. It failed in a proper understanding. It canceled all elective surgery in all hospitals. It crushed the P&L of hospitals, crushed them. Because even though it was 30% of the volume, it was 70+% of the profit of a hospital came from elective surgery. So they all went into a hole, some of them at 20 million a month, some of them at 75 million, 100 million a month. So it crushed them financially because we weren't prepared. And then now the negative impact of patients afraid to go to the hospital. There's just so many things that disoriented the people that run what we call the health system, which is hospital-centric. So I think the pandemic was one of those, in the Hindu religion, the god Shiva, she's the destroyer. It destroyed the level of confidence in that institution, causing an openness for what's going to follow. And there's a lot of people who believe that's what's going on in politics as well, and in the media as well. It's just a feeling. I just came back from Sacramento, Oakland, Roseville, and Portland, Oregon. I had to evacuate my son from Oregon University in Eugene, 750 parts per million of smoke. There was smoke in his house. The smoke turned on the smoke alarm in the house, the smoke from the outside. There was smoke in my hotel room. And there it is. The streets are boarded up because of the disturbances that went on the streets. They're all covered in graffiti. Streets are full of smoke. And the hospitals are struggling and afraid of the next wave of COVID coming. It felt like we're in some dystopic dream, bad dream. But the impact I think it's having, Kyle, is it's a propellant for something that's going to change, that's needed. We're a very, very bright country. We're incredibly creative. We can do almost anything. I believe we could do anything as a country. We just needed to tear down some of the things that aren't working anymore. And I think that's what COVID-19 did. It tore down our confidence in things that needed to be torn down anyway. But rather than a death of a 19 cuts or 1,000 cuts, it was a sledgehammer. And I think that's what's opened the door, not just for Medically Home, but for a lot of folks, a lot of companies. But the other thing I want to say it really with a lot of energy. When I was a little boy, I heard that the first 747 was landing at JFK in New York. I lived in Brooklyn in New York at the time. And when I saw a picture of it on TV, it looked like a city. I didn't believe it could actually take off or land. So there was no security back then. So I took my bicycle. I cut out of school, which I shouldn't have, but I did. And I drove my bike to the runway at JFK. And I lined there in the grass. And as I watched American Airlines Flight 1 land, and the 747 right above me. And the level of patriotism I felt for our country, the same feeling I had when Neil Armstrong stepped on the moon. We're capable of anything, but we've become so financially oriented in worrying about financial risk. We've so tried to mitigate out of our consciousness that only big things really matter. Only really big, hard things to do matter. Because doing the little incremental things doesn't really allow us to progress as a country and as a people. So I'm worried about everyone's fear of the complexity of this. It's everything awesome is complex. That's why it's awesome, because in a current status quo, it's not awesome. It needs to be changed, which means you have to undo it or change it or disrupt it. So the capital, and the people that manage the capital, and the people that review the management of the capital, is no longer oriented for the really big, shots outside the park. It's more incremental, and it's more, you have to prove it through the windshield, or the rear view mirror. Everyone asks me, like, what's the pro forma look like? This is 10 years ago. How do I know? I don't even know when we'll be able to do our first patient. How do I know what the pro forma looks like? I could lie to you. I could show you all the different admissions and our pricing, which I don't even know what that is either. the belief in people and in ideas and leaders to go after the really, really big problems, to solve them, is where capital, some part of our capital should go. It's not venture capital, and it's not traditional PE, which needs historical, some traditional historical financial results to be able to justify its investment. There's a gap in the capital market, I think, for big ideas. But anyway, we got there through all strategic investors. And in fact, our Series A, 127 individual physicians invested in Medically Home. It was like a Kickstarter campaign. Yeah.
Whoa.
And they're all very happy. They're all very happy now. They're all really happy now. Yeah. So anyway, that's my commercial about doing big things and not being afraid of doing big things.
It's incredible to see someone like yourself have the patriotism, but the ambition to tackle such a hard problem, and that's kind of been the backbone for, especially within the United States, for the many of the things that we've accomplished. And I think this is, unfortunate the pandemic has the destruction that it had, but at the same time, it's a silver lining and a reflection moment, and also an incredible opportunity for disruption that to realize for a lot of people what should be done versus just keep the traditional process that we have. And I think it's really incredible. Jamie was saying that you're the Steve Jobs of healthcare, and I 100% see that now. Absolutely incredible. Well, Raphael, I have one last question, and you probably already answered it a couple times, but I guess, what do you think the future of telemedicine, or in your case, in home care, provider care, what do you think the future of that is? And what do you see that most people don't?
Well, we did a press conference last week. John Halamko is the president of the Mayo platform, and I did a press conference. It was sponsored by Google, and a lot of media was there, and someone asked me that question. And the question had embedded in it a supposition around technology, and I challenged it. So I think the future is uncertain, Kyle, but through my lens, I'm going to tell you what I'm going to do with every breath left in my body to make the future I'm about to tell you happen, instead of the future that everyone else is talking about in healthcare, particularly healthcare tech investing. When you're sick, I have cancer. So I've been through a lot. Both of my parents were Holocaust survivors, and illness, and my brother died of Tay-Sachs disease. So sickness, illness, death, my ecosystem. I grew up with it. I live with it. Medical care is 50% science and 50% spiritual healing. When you're sick, you're afraid of dying. There is no medicine for dying. There is no recovery from dying. Dying is the most existentially pure and simple question that's been going on since we were conscious human beings. We're afraid to die. We just are. And when we get sick, we're one step closer to understanding that we might die. So when we're ill, particularly seriously ill, particularly hospitalized, in the back of our minds, are we coming closer to that point in time where we as a Western culture, we don't want to talk about death. Other cultures are a little bit more intimate with it, but we're not. We're afraid of it. So here comes the hospice nurse. Oh my God, I don't want hospice. That means I'm going to die. But you are going to die, and hospice is going to help you. No, I don't want to talk to hospice because I don't want to die. So in the end, 50% of healthcare is spiritual healing. It's actually talking to your soul about its fear of death, about comforting you, about caring about you, about making you less afraid. And the only way you could make me less afraid, if I'm afraid, is if you look at me and you honestly say, how are you today? You hold my hand and you look into my eyes, and I realize you were born to heal. You've been called to care for me. No freaking AI app. No artist does that. There is that. No app calling you and saying, how are you today, Mrs. Schwartz? Did you take your beta blockers today? That's not a sentient being calling you. That's not healing. That's a mechanical process trying to replace a human process. So 50% of medicine is healing. Healing is done by healers. Healers are called to care for people that are vulnerable and afraid and sick. That's what healers do. So the future that I see is technology is in service of healers. not replacing them. The direction we're going is replacing them. We're creating more and more apps, more and more menus, more and more tech to replace the thing that causes people to safely navigate illness, which is human comfort. Which is why when the doctor came to your house at the end of the day, wearing the stethoscope, holding your hand, that was medicine. Even though the doctor didn't have CAT scans yet, didn't have really sophisticated, customized medication for cancer, yes, you died much younger, but you actually felt cared for. And we're all going to die. We're all going to die. The question is, how do we choose to die? And how do we choose to live? So I think the future of medicine, if I have anything to say about it, is to take real healers, and I'm blessed, every one of the 100 people in my company is a healer, every one of them is a healer. Arm them with technology that allows them to be more effective with patients, as opposed to replacing them. That's the future that I see. So there is no investment thesis around how that looks yet. When I talked about tethering, having a paramedic come to your house, one of them are firemen. People love firemen. Fireman comes through the door, patient sees them, they're already feeling better, right? And then there's on the screen, there's the doctor who they love our docs. So they're talking to the doctor, the paramedic's there. That's healing at work using technology. That's healing. So to me, the future is healers using technology, not healers being replaced by technology. Now, I'm probably wrong in terms of where you're going to bet your investment money, Kyle. I'm one tiny little voice, although medically home is having a gigantic impact. And I'm hoping, and the reason I do things like this, I'm hoping to spread the word that there is an obvious gap in the way we're thinking about medical care going forward. And one last thing, if I took 100 doctors, put them in a room, male, female, young, old, and I have every one of their mothers is ill, and I have the actual case notes on their mothers and the back of the picture of the doctor in their CV. Here's the doctor in their CV, here's their mom and their notes. And I say to them, you have a choice. You could put your mom in the hospital, whatever hospital you're affiliated, or we could take your mom home and do what Medically Home does. You know, not one doctor would send a patient to the hospital, not one, because it's their mother, because they love their mother. They love their mother. And they're not going to put their mother in the hospital if we could do all this for them at home. And I've done that, Kyle, over and over and over again. I've done that for the last 12 years. If we could do all that, I want her home. Of course I want her home. It's the same doctor that's saying I'm afraid to take care of the patient in the home because, so it's healing and what we need to do to care for patients is obvious. It's in the heart, but we're losing sight of that, and we're creating processes, workflows, handoffs, transitions, industrial. And I know a lot about industrialized processes because that's what I did for a big chunk of my career. I built and redesigned factories. That's what I did. Human beings are not on an assembly line that you're putting a UPC code on and throwing it into a carton. They're souls. They're souls. They're close to God, and we're not supposed to be doing that to them. So that's my soapbox. Thank you for listening to that.
No, that was incredible. I absolutely blown away. And I think it is, and it's important to speak on this topic because healthcare is such a complex ecosystem that it's not just we can find a tool that'll just replace what already exists. It's how do we find the right tools to enable those that can provide better care, improved care, more efficient care. And I think you really, you say it better than anybody else. I can't even repeat. I can't even summarize. It's absolutely incredible. With that, Raphael, I don't know if do you have any other closing remarks or ask of the audience or anything else, or besides that, I'll close out because this was a fantastic interview.
No, I thank you so much for the opportunity. I've never had this much time to actually share everything that's in my heart. So thank you for that. I really appreciate it.
Absolutely. And I just for the audience, it's we spent well over a lot of time looking at well over 500 telemedicine services, and telemedicine, associate the word with medically home, definitely does it justice. But we had, I think it was great to have the opportunity to talk with Raphael today to really highlight the importance and the structure and the ecosystem, the platform that you've built, and how that changes care globally, really, I think, and it's really the entire direction of care will change with Medically Home. And I'm really, really happy we got to do this. So thank you, Raphael.
Thank you
I really
so much.
appreciate
I
it.
really appreciate it. Thank you.